Okay, so pulmonary embolism, that means what we're looking for, the S1, Q3, T3 pattern. So in the S wave, it's going to be in lead 1, S1. It's going to be a deep S wave, which we see here. QRS, deep S wave. And then in lead 3, we're going to have Q3, S1, Q3. So now the Q wave is going to be deep, which is QRS, like so. S1, Q3, T3. So there's also an inverted T wave in lead 3, which we see here, because this is supposed to be up like so, like so, like so. So as you can see, the T wave is inverted. So these are the 3 signs whenever we have pulmonary embolism. So inverted, we'll do it backwards now. Also in 3, deep Q wave, Q here, and then S wave, QRS, deep S wave in lead 1. We also have new bundle branch block, which is why we see the double firing, the rabbit ears of the ventricles, like so. And what else is ST, segment depression, V1 through V3. So ST, elevation depression, boom, boom, and boom. V1 through 3. Segment depression, not elevation. Cool. This shows severe hypothermia. So if somebody is dropping in temperature, patient may develop a J wave, or called the Osborn wave, which are often large, upright, occurring on terminal wave of the QRS complex. This is the end of the QRS complex. Not at the beginning here, but towards the end, boom, J wave. So that is signs of hypothermia, and they'll have typically a very low heart rate. You might think they're dead, but it's just extreme bradycardia. Reveals a bradycardic rhythm and baseline containing artifact from shivering and poor electrode adhesion, probably because of all the goosebumps that are popping up. It's not allowing a seal. Electrolyte imbalances. So we have hyperkalemia. Kalemia, potassium, it's going to go up like a spike, like so. If it was further along, that would be not calcemia, potassium, sodium. Hyperkalemia, hypercalcemia, what is sodium? Hypernatremia is magnesium. This should be easy. Hypercalcemia, hyperkalemia, I don't know, we'll see it. So tall peaked wave is kalemia. Asymmetric T waves develop. Yeah, so I mean, it's kind of hard to see where it even starts, but that is not symmetric as far as the T wave goes. P wave can become flattened and even disappear altogether. You can see that it is encroaching almost. Actually, that's not even a P wave. No, QRS. In severe cases, the wide QRS complex widens. There's not really a measurement on there, so it's hard to say that right now. Hypokalemia, hypercalcemia, hypokalemia, flat, unseemingly absent T waves. Oh, wait a minute. Hyperkalemia, hypokalemia. Yeah, so it's the opposite. I'm still trying to figure out what the potassium is. So if they have excess potassium, it's going to spike. It's going to do the opposite if they have the opposite, which would be less. So you have a pancake, flat, seemingly absent T waves such as that. And I forget when U waves develop. I want to say it also has to do with hypothermia, or in this case, development of a U wave. U waves are rare, usually mistaken for an extra P wave or another abnormality. Probably has something to do with the heart needing to fully repolarize. So because it didn't get that extra bump of juice, it's like, all right, throw another one in there, and that's the U wave. That's my theory on it. I really don't know. These are right. Yeah, these are right. I can't tell. Okay, this is going. Okay, hypercalcemia may produce a shortened QT interval. Hypocalcemia may be slightly lengthened in the QT interval. So both lengthening and shortening are entirely due to the length and change in the ST segment. T wave is unaffected by calcium concentration changes. So it's going to slightly lengthen the QT interval. Cardiomyopathy. This is a condition in which the heart muscle weakens, diminishing the ability to pump enough blood to the rest of the body. The main type of cardiomyopathy is dilated, hypertrophic, and restrictive. Hypertrophic cardiomyopathy is a genetic condition which the myocardial wall becomes very thick, impairing ventricular filling. Patients will experience, often associated with physical exercise, so you're going to have shortness of breath, chest pain, syncope, could just pass out altogether. Often diagnosed in the patients in their 30s and 40s. Characteristic by a deep, narrow Q wave in the inferior and high lateral leads. So what's our inferior leads? Sally, inferior, down here. 1, 2, AVF, pretty sure. Yeah. And then lateral leads, V5, V6, maybe V4. That's more so septal or anterior, but at least V5 and V6. So we're going to see the deep narrow Q wave. Maybe we'll get an example in the left precordial leads. Yep. In most cases, disease is inherited. In other cases, the cause is unclear or unknown. With restrictive cardiomyopathy, the ventricular wall stiffens due to abnormal amount of substance deposited between the heart muscle cells throughout the heart because the inner surface of the heart is lined with scar tissue. The rigidity of the ventricular wall hinders ventricular fillings, and the heart eventually loses its ability to pump adequately. So I like to relate everything to calluses on the hand, right? So the more that it, this is more so it's like bearing down, so it's heavily keratinized skin there. But it's thicker, it's more rigid, and that's what's happening with scar tissue that builds up in the heart due to damage. So this is like physical damage of the skin, grabbing a bar with rough sandpapery like surface area. Yeah, we went through all that. Okay, so this figure shows a 12-lead electrocardiogram that is showing evidence of hypertrophic cardiomyopathy. So let's try to remember what we were talking about. So in the lateral lead, Sally, we're going to have Q waves, deep Q waves, which we do have we have it more so in here. So we have Q, R, S. Yeah, we have deep S waves too. V5, V6. We have super early P waves. It looks junctional. Q, Q. So V4, V5, also V3, not in V1, V2, Q, Q, Q. What does this say? Left axis deviation, right bundle branch block, left ventricular hypertrophy with repolarizing abnormality. If it's left, yeah, it should be left. Anterolateral infarct, yeah, because that's what this is happening all in V3, connecting the V4 and V5 group. What else is happening? It's not really normal, but it's more normal than the rest. No, it's not at all. So T wave is inverted. P wave's inverted. P wave's also inverted. P wave is right up on there. You have some elevation, it looks like. There's all kinds of crap happening. And then you have the QRS, ST elevation with a little bump. Yeah, I would just look at cardiomyopathy, look at pericarditis, and I forget what the other one is, but there's a lot of different things going on. Let's just go back and see what it says. Okay, so condition in which the heart muscle weakens, diminishing ability to pump. Yes, what do we see in the EKG? So deep, narrow Q waves in the inferior and high lateral leads. And we saw that. Deep, narrow Q waves in the high lateral leads. So these are lateral. but these are almost, it says high lateral. I guess Q. So V4, it's not as deep. Connecting to V3, it's deeper. So I guess V2, V3, and V4 are considered high leads. I figured it would say V6 and V5 would be high leads, but maybe not. QRS. And then what else do we have? Very tall R waves in the left. Precordial leads. Precordial leads, left. Well, these are R leads, so QRS, but it's also high in here too. I mean, these are all precordial leads. Whatever. And that's really all it says. It doesn't say anything about the U waves and all that. All right, Brugada syndrome, genetic disorder that is involving sodium channels in the heart, characterized by incomplete right bundle branch block. The ST segment elevation that aggressively returns to baseline, changes in lead V1 to V2 and possibly in V3. ST segment elevation, incomplete right bundle branch block, often undiagnosed until patients are 40, 50, or suddenly onset with syncope or cardiac arrest. So very aggressive start to finding out you have Brugada syndrome. And yeah. So let's look at V1, V2, and V3. V1, V2, V3 changes. That looks the same as this, same as that, looks the same as that. I mean, it's kind of got a little bump there. I'm not sure where the difference is. T waves is the same. P waves, it's kind of hard to find the P wave. P wave. All right, so let's look at 2. That looks the same as that, copy, copy, paste. That looks the same as that. So, does anything look different in these? Because I'm not seeing what it's telling me to look for. Changes in leads V1 to V2. So these aren't supposed to look the same as these, I think. It's a terrible example. Incomplete right bundle branch block. What do we see in right bundle branch block? We see rabbit ears. So we see that in lead 2 and AVF, but we don't, so it's incomplete, but it's notched. And we should have elevation or depression. Where do we have depression? AVF has depression. Yep, that has depression too. This figure shows a 12-lead electrocardiogram showing evidence. Yes, we know. We know. Long QT syndrome. Long QT syndrome. So QT interval exceeding 0.45 seconds. The heart experiences a refractory period that may create a ventricular dysrhythmia. So it's not supposed to be this long. As you can see, it's depression and it hangs out for a while until it finally catches back up. This is long QT syndrome. Characterized by QT interval exceeding 0.45 seconds, indicates the heart is experiencing an extended refractory period which predisposes the ventricles to dysrhythmia. It's going to be a result of genetic mutation of several genes, administration of certain drugs such as amiodarone. Amiodarone is very dangerous, but it's last resort if somebody is already dead. Certain conditions such as hypocalcemia, acute myocardial infarction, and pericarditis. The QT interval is age-specific and gender-specific as well. Patients are at increased risk of ventricular dysrhythmias, including torsades de pointes and VFib. May cause deeply inverted symmetrical T waves in the precordial leads in a prolonged QT interval. The patient will almost always have neurological symptoms or be unresponsive. So look for altered mental status if that's the case. Deeply inverted symmetric T waves. Oh, did they finally transfer? That'd be nice. T waves in the precordial leaves and prolonged QT interval. Deeply inverted. So let's look at the next one. Precordial leads. T waves, deeply inverted T waves. That is a T wave. Yes, and it's symmetrical. We don't want symmetrical. But these are symmetrical. So V4, V5, V4, V5, V6, also V3, V2. So all of them except for V1. So, all right, finally seeing what it's telling me to see. And then what else is a symptom? Prolonged QT interval. And a prolonged QT interval. So yeah, it's pretty lengthy. QRST. QRSRT. Pathophysiology assessment and management of specific cardiovascular problems. The epidemiology of cardiovascular disease, according to the American Heart Association, cardiovascular disease, CVD, is the leading global cause in death. It's estimated that more than 1 in 3 Americans has one or more type of cardiovascular disease. Then we have coronary heart disease, CHD. I'm on the right slides, right? I think so. CHD is a disease from the coronary arteries and associated signs, symptoms, and complications such as angina pectoris and acute myocardial infarction. Patients with CHD have 5 to 7 times the risk of having a heart attack or even dying, characterized by the atherosclerotic narrowing and eventually blockage of the arteries that supply the heart muscle with blood. Acute coronary syndrome, ACS. This is characterized by diminished flow through the coronary arteries, coronary artery occlusion by a blood clot, also known as a thrombus, and coronary artery spasm. Reduction of the overall blood flow from any cause. If the blood vessels become blocked, tissue that deprives the oxygen and nutrients of ischemia. Whenever the ischemic process is not interrupted, you're going to have death of cell tissue, heart tissue. This is what infarction is. The etiology is the usual cause of acute coronary syndrome is the rupture of an atherosclerotic plaque. So the plaque that builds up if you eat too many fatty cholesterol and you don't eat enough Cheerios apparently, that's going to cause that plaque to break off somewhere in your body where it's built up, eventually become a thrombus and block the rest of you.